Thank you so much for that, all of that input on our first session on symptoms and daily impacts of living with CDD. We're going to have plenty of time for more discussion to really build on that earlier discussion, but in the context of looking at what are the current treatment approaches that we have, treatment approaches being broadly defined not only as pharmaceutical drugs or prescription drugs, but also other things that you might utilize, whether that be things over the counter, medical procedures, medical devices, diet, exercise perhaps, or even lifestyle modifications. So anything that you might use to try to help treat or manage and live with CDD. And we're gonna, in this session, explore how well those things are working, as well as what the downsides are of currently available treatments. And then we're gonna end by looking towards the future and getting your thoughts and preferences around what you would be looking for from that next future treatment. So to get us started on this topic, we have another panel for you. We have Kristen, Martha, Rita, Amanda, and Ed, who are gonna be sharing their and their children's and grandchildren's stories. So I'll go ahead and ask Kristen to kick us off.
Thank you. My name is Kristen. I live in a suburb of Philadelphia with my husband, Brian, and our 3 daughters. Our youngest daughter, Avery, who is 5, has CDKL5. Avery was diagnosed when she was just 4 months old. At the time, they had just added CDKL5 to the infant epilepsy panel, and Avery was one of the youngest patients diagnosed. Since her diagnosis, Avery has tried and failed 4 different anti-epileptic drugs. She is currently taking Onfi and Depakote, as well as taking part in the ganaxolone clinical trial. She's also on the very strict ketogenic diet. Her diet is 90% fat, 7% protein, and only 3% carbohydrates, so no Halloween candy this weekend for our little girl. Avery takes 5 supplements: a multivitamin, calcium, vitamin D, magnesium, and selenium, as well as a daily probiotic to compensate for the vitamins and minerals missing in her diet. Avery had surgery in 2018 to place a G-tube after losing her safe swallow during an episode of status epilepticus. Since then, she has struggled with many of the GI symptoms all too common in children with CDD. To combat excessive reflux and vomiting, she takes ranitidine and omeprazole. She also takes a low dose of erythromycin to help her with gastric motility. Each of these drugs have their own dosing guidelines. Some need to be taken before food, some need to be taken with a meal, some are taken 3 times a day, while others are taken twice a day. All in all, we give Avery a dose of medication at 6 different times throughout the day, which interrupts her normal learning and play. Additionally, each of her meals is considered a dose of medication. For the ketogenic diet, we need to weigh everything to the 1/10 of a gram and ensure that she eats it in its entirety within 30 minutes. Even with all of this, Avery still has 4 to 6 big seizures a day. She still suffers with GI issues. We still find ourselves cleaning up vomit and having to give her suppositories to induce a bowel movement. Some of the drugs we have tried have worked for a while, and then their efficacy has dwindled slowly. For example, she was on Topamax for years. We saw a stunning improvement in seizure control when she first started the drug as an infant. So we put up with the major side effects of appetite suppression, heat intolerance, and acidosis. But slowly, over the course of 2 years, the seizures crept back in, getting longer and more intense until she ended up hospitalized. Some of the drugs we've tried made it clear very quickly that they were not the drug for Avery. In the case of Keppra, the medication made her seizures skyrocket to over 100 a day. The ketogenic diet is a particularly difficult treatment to evaluate efficacy because it can take a very long time to work. When we first started it, we noticed some seizure reduction, but the real reason we are still on it is that we immediately noticed some increased cognitive ability. She made better eye contact and was able to focus on tasks for longer. We are still on the diet because, frankly, we are afraid to remove it and risk losing this side effect. We are a very active family and we love to travel. Avery has traveled the world with us. In order to facilitate this, we must plan and prepare. To travel, we pack her pump, her formula, her scale, and her blender. We pack her medications, her syringes, her pulse ox machine. We pack her diapers, her rescue medication, her speech-generating device. You should see us try to get through the TSA checkpoints at the airport. This is our life with CDD. Is it hard? Yes. Is it worth it? Absolutely. What would I like to look for in an ideal treatment for my daughter? The answer to this question has evolved so much since her initial diagnosis. 5 years ago, I would have said seizure control. Do whatever it takes to make these awful, heartbreaking seizures go away. Now, my number one focus would be increased cognition. I truly believe that Avery is in there, that she is stuck inside this little body that will not cooperate. There was one of those things circulating on social media a year or so ago, posing the question, if you could have a conversation with anyone, dead or alive, who would it be? Everybody else is answering with lost loved ones, influential people, or historical figures, my grandmother, Bill Gates, the Dalai Lama, things like that. But the only answer that I could think of was my daughter. She's sitting right here beside me, but she cannot tell me what is on her mind. I would give just about anything to sit and have a conversation with my girl, to know her, to really know her. What is her favorite color? Who is her favorite princess? What would she like to be when she grows up? So while I, of course, would love better seizure control and something to help her GI symptoms, a treatment that would allow her to interact with us, to joke around with her sisters, or tell her daddy that she loves him would be worth its weight in gold. Thank you.
Hello, I'm Martha Boyles from Lexington, Kentucky, mom to our sweet, almost 14-year-old daughter, Elsa. Like all first-time parents, when she arrived, we were ecstatic that she had all 10 fingers and toes. But within about 6 weeks, strong startle episodes, which eventually proved to be infantile spasm seizures, came into play. She was not visually tracking objects and was light gazing. Elsa is on the more moderate to severe side of the CDD spectrum in some aspects, but has blessedly been spared other challenges of the disorder. For Elsa, decreased gastrointestinal motility has manifested mostly as constipation and severe abdominal cramping. When she was 5 to 7 years old, any significant degree of constipation was clearly linked to an increase in her seizure activity. Over the years, to help with the constipation, we've had to continually adjust the approach. High-fiber foods, adding fiber supplements, probiotics, magnesium citrate, and her body seemed to acclimate to each change, and she required more to maintain some degree of regularity. It was not until she was prescribed Senna at the age of 7 that we saw a more consistent resolution to her constipation. She seems to need that particular stimulation from Senna that her own GI system is lacking. In the past 3 years, as she nears puberty, Elsa's seizures have evolved into a cycle, with 2 weeks of intense seizure activity followed by a 30-day break. During the 2 weeks of seizure activity, Elsa is fairly lethargic and has severe bowel cramping on a daily basis. Even a 30% increase in GI motility would help her to recover more quickly and minimize those severe cramps. Although Elsa has been on 9 different anti-epileptic drugs in different combinations, one of the main interventions that has improved her seizure control the most has been the modified Atkins diet. The modified Atkins diet has improved her seizures by 60 to 70%, although it took close to a year to see the full benefit. The only time that she was not on the diet was when vigabatrin was weaned and Vimpat was added as her main medication. This change led to uncontrolled daily seizure activity and an almost complete loss of her ability to swallow. Although we had quickly gone back to vigabatrin, she only regained good seizure control, 1 seizure every 4 to 5 days, once she was fully back on the modified Atkins diet. With that diet's reduction in seizures, Elsa is actually able to make progress in her physical therapy goals and enjoy more outside activities as a family. Decreased bone strength has been a persistent issue for Elsa since she had a hip surgery in 2015 for a progressing subluxation of her right hip. She went from standing well with very minimal assistance at the hip for 30+ minutes to only wanting to stand for a few minutes at a time. Unfortunately, the stiffness of her bones and the stiffness of the plates were not good matches during the strong tonic muscular contractions at the start of her seizures. She has suffered 4 complete fractures of her right femur around the plates. We use a knee immobilizer during the intense seizure cycle to help limit the degree of contraction of her hamstrings. And although the immobilizer has helped, it limits her ability to move freely on her playmat, adjust positions in her sleep, and sit or stand comfortably. Although Elsa gets the plates removed as soon as possible, future therapies focusing on improving bone strength would give her an increased ability to stand and walk with assistance. With Elsa's visual processing challenges, we sought out a cortical visual impairment specialist to help us with the best strategies to present visual information to Elsa as a baby. She had us initially present one object at a time in red hues that Elsa would visually attend to against a dark background. She can now handle more visual complexity and also uses a head switch with a recorded message to select her preference when verbally given choices by a partner. Until she could use the head switch in this manner, we had no idea that Elsa's favorite color was actually purple. Her CVI brain would tell her to notice the bright colors, and she would look at those quite quickly with her eyes. But when given verbal color choices, Elsa always chooses purple. We would love to see more research and therapy directed at visual processing and the ability to identify what she may actually be seeing. Is it double? Is it fragmented? Is it inverted? In a nonverbal child with moderate CVI, understanding how Elsa sees is critical to us if she is to make any real progress in her ability to make associations and to learn. Even a 20 to 30% improvement in her functional vision could allow her to make those connections and engage more in the world around her. For Elsa, the inroads into addressing gastrointestinal motility and cortical visual impairment would benefit her the most on a daily basis. We have a long way to go to formulate the best treatments for children with CDD to alleviate pain and give them the chance to experience and enjoy more of life. Elsa loves to cuddle, and at the end of a long workday, she gives us all much more joy than she knows. Thank you.
My name is Rita Fredericks, and I am mom to 9-year-old Liam and 4-year-old Miles Fredericks. We are from Grimes, Iowa, a suburb of Des Moines. Miles was diagnosed with CDKL5 at the age of 4 months in September of 2015. The first symptoms we noticed were seizures, unusual eye movement, no looking at or interacting with familiar faces, no response to sound, voices, or music, and difficulty nursing. These dual impairments, physical delays, and intractable epilepsy continue to impact Miles today. Currently, Miles is on the ketogenic diet, a nutrition-based diet supplemented with macronutrients used to assist in seizure control. He takes 2 AEDs and additional multiple medications to counteract the effects of his diet and the AED by keeping his organs and body functioning, medications to manage his respiratory airway disease, and controlled home suction to keep his airway open. Additionally, he has multidisciplinary therapy sessions, physical, occupational, speech therapy, and reflex integration. Over time, Miles has tried 6 different combinations of AEDs. Some were used with the ketogenic diet as well. He started on seizure medications when he was 9 weeks old, and he started on the ketogenic diet when he was 5 months old. Miles' seizures have increased in types over time. Currently, the intensity of the physical movements and the rigidity of his body and the length of seizures from 2 minutes to now clusters of seizures lasting about 45 seconds have decreased with treatment. But the frequency has only slightly decreased by 2 to 4 per day. Our son's cognitive impairment, vision and hearing impairment, feeding delays, GI, nonverbal status, and physical impairments have remained severely delayed with very little development or progress, even with multiple weekly therapy appointments and therapy intensives, and with his diet and medication treatments. Additionally, Miles was recently diagnosed with brittle bones due to his CDKL5, low tone, and treatment side effects. His bones are like straws, hollow inside. We aren't able to access treatments yet, as we need him to break a bone first for insurance approval. There is a variance in his symptoms based on seizure activity. During times of increased seizures, he has a harder time participating in therapies, school and social, home life. For instance, we're a family that loves to ride bikes, and we recently were able to get an adapted bike that Miles can join us with. But he's unable to keep his little physical strength to sit in the seat properly without cutting his airway off during times of increased seizure activity. This is an activity he loves and connects with. The movement and the breeze on his body and in his face speaks to his sensory and vestibular needs. Fatigue and circadian rhythm dysfunction leaves him unable to stay engaged with activities that would help strengthen and maintain his skills and abilities. He loses stamina and he becomes very agitated and often gets sick with respiratory or GI illness. With these types of setbacks, he is constantly running a marathon. This leads to very slow, minimal progress. The most significant downside to Miles' treatments are the lack of flexibility in his schedule due to his therapy, medication, and feeding, and the hard-to-explain impact on our family life together and on the physical and mental health of our family overall. His AEDs impact his brain development, personality, kidney and liver function. His diet impacts his ability to gain weight and grow at a typical pace and impacts his kidney, liver, and GI function. Both result in him needing to take additional medications. Miles sees 17 specialists at 2 children's hospitals in 2 different states. This ensures his care and treatment is being managed, and we're able to discuss any concerns or needs. The cost to our time, our car, our family are hard to put into words. We all have been in some type of counseling now to work on how we manage the stress and emotional impacts of raising and caring for a child with severe disabilities such as Miles, and those impacts on his sibling Liam as well. With the dual sensory impairment, it is difficult for Miles to get on a schedule with his wake and sleep times. This is a known symptom of CDKL5 and tends to get worse with age and leads to children being awake for days on end. Our home has become a live-in therapy and care facility. It's not a typical home because of Miles' needs. Miles has a soft play area where he's able to explore and interact with Switch toys in the hopes that he will learn cause and effect. He has a hammock-style swing that hangs from a ceiling in our dining room. This helps him receive his vestibular input that he needs often. He has a little room to help teach him spatial recognition and to help him understand that there's a world around him. Ideal treatment would see better seizure control for Miles. Fewer seizures would lead to less damaging side effects on the developing brain and increased neurological function and neuron development and transmission and brain processing abilities. Improvements in hypotonia, physical skill development, improved language acquisition, sleep patterns, and organ body function are priority concerns. Miles' symptoms are managed in a way we tolerate, but are not improved and are not controlled to the best level we would like, or to a level that allows Miles to progress in a way that is meaningful to him. Help us make this adventure meaningful for Miles and for our CDKL5 family. Thank you.
Good afternoon. Good afternoon. My name is Amanda Jackshaw, and I am here today from Loveland, Colorado, as a mom to Ava and Eliza. In 2012, around the age of 6.5, Ava received a molecular diagnosis of CDKL5 deficiency disorder. Her diagnostic journey began when she was around 7 months old, after having her first motor seizure and some vision concerns. Ava endured thousands of seizures and failed most available anti-epileptic drugs, or AEDs, by the time we identified the small deletion causing a reading frame shift on her CDKL5 gene. She is now 14 years old and attends a public education school with a focus on augmentative and alternative communication, or AAC. Currently, Ava's maintenance AEDs include divalproex sodium, clobazam, diazepam, and an investigational drug. AEDs have historically provided Ava relief for only short periods if they work at all. We have tried phenobarbital, topramate, oxcarbazepine, zonisamide, rufinamide, gabapentin, and rescue medications including clonazepam, Diastat, and midazolam. Sometimes AEDs make things worse for Ava. Over the years, she has experienced serious and life-threatening side effects from drugs used to treat epilepsy. Before her CDD diagnosis, around age 4, she acquired electrical status epilepticus during sleep caused by oxcarbazepine. It led to the addition of high-dose diazepam at night that continues today. At age 10, she narrowly escaped liver failure from a severe drug hypersensitivity reaction known as drug rash with eosinophilia and systemic symptoms, or DRESS syndrome, shortly after we introduced a second-generation AED adjunct therapy of rufinamide. DRESS syndrome is rare and not well understood. There are no treatment options other than withdrawal of suspect drug and high-dose steroids. It took a 4-month treatment course of prednisone to bring her liver back to baseline from near failure. A few months later, she contracted mycoplasma pneumonia that triggered a 20-day hospital stay, including 14 days in the PICU. 10 of those days were spent intubated. It was the first and last time to date she has experienced a respiratory illness requiring hospitalization. As Ava neared the onset of puberty, we again lost functional seizure control. We prioritized her abrupt need for a spinal fusion over a vagus nerve stimulator placement, leaving us with few opportunities to address this decrease in her quality of life. Fortunately, we learned of trial options on the horizon, and despite weeks of documented seizure observation and a diagnosis synonymous with refractory epilepsy, we still had to provide an additional 6 weeks of observation data to join a study. Ava had an additional 115 motor seizures while we collected that data. Once she began the experimental drug, she experienced an immediate increase in seizures, and a few days later, a gradual reduction from baseline activity emerged. To our surprise and delight, her anxiety and ear-piercing vocalizations decreased substantially within the first 6 weeks. Her gross motor skills also became more fluid and sustained, as noted by her physical medicine and rehabilitation doctor around 3 months after reaching the maintenance dose. For the first time in her life, we attended medical appointments without her wheelchair, as she was able to stand and ambulate for longer distances without a need to rest. Expressing her voice more proficiently with her eye gaze communication device has also improved. Using your eyes to communicate takes an incredible amount of muscle control and motor sequence planning, as well as highly specialized speech and language therapists. In the past 4 years, she has gone from using 4 large symbol buttons via hand selection to using eye gaze on to 8 to 12, up to 24, and currently demonstrating she can handle 45 buttons to communicate. Her desire to share what she is thinking is strong, and the impact of gaining this skill is undervalued. One of the most unbearable aspects of CDD is knowing that your child is desperately trying to tell you something, but not truly being capable of hearing what it is they are trying to say. Communication is a fundamental human right, and the barriers of access to these systems are steep for intellectually disabled people. Identifying specialists with the skills to appropriately assess, fund, and implement AAC systems is a tall order. Communication beyond yes, no, and request is possible and life-changing for both patients and caretakers. Today, Ava can greet her peers, say I love you, tell us to go away, that she feels diabolical, hangry, sick, or content. We remain in the extension study for the investigational drug, and her baseline seizure count has decreased markedly. While her epilepsy remains refractory, the other changes I spoke of have improved our quality of life beyond anything imagined. I have hope for a day when Ava can use 1 or maybe 2 drugs for seizure control that don't make her agitated, constipated, floppy, or sleepy, to help her better communicate, to improve her ability to self-feed, toilet, and dress with minimal support, to reduce the burden of severe anxiety and behaviors such as loud and constant vocalizations, self-stimulating, and self-abuse are life-changing improvements. Developing drugs that focus on global brain outcomes beyond seizure reduction is an urgent and unmet need in the CDD community. I'd like to thank you for giving me the time to share my story today.
My name is Haley Hilt. I am a 12-year-old CDD girl. My grandfather is reading this for me. He has helped Mommy and Daddy care for me since birth. I am here today with my mom, Melissa. We hail from Schodack, New York, which is a stone's throw from Albany, New York. Everyone here should already know some basic things about CDKL5's major impacts. But what you may not know is that I am normal in some very important ways. My receptive communication is clearly intact. When I choose to, and when I can, I think quite clearly and speak quite clearly with my eye gaze computer. However, I am constantly impeded by my disabilities, not the least of which is my intractable epilepsy, motor impairments, and my cumbersome eye gaze talker. My current treatments include 2 epilepsy medications, as well as PT, OT, and speech, music therapy, all of which are provided by a great school program. These therapies are challenges I welcome, but they are limited in their effect. Yet I hope one day I can overcome my limitations, but the odds are against me without help from this community. I hope that is not news to you. My future lies in the outcomes of focused research, exhaustive review of related research, and a vigorous battle against the often secretive and proprietary ways of basic science research. Let us deal with my epilepsy first. Not a day goes by wherein this is not an issue. To overcome, we have tried approximately 16 anti-epileptic drugs. Think about that. 12 years, 16 meds, each of which requires a titration period, all with varying side effects. Some side effects require the meds be stopped. Others require an adjustment period to get through transitory side effects, or, in the alternate, a weaning off period and subsequent search for a new drug to begin the cycle again. And as I grow, seizures wax and wane in both kind and severity. It has been a lifetime of titration and side effects. And let's not lose sight of well-intentioned MDs possessed with solving each and every seizure problem, as if that was my only problem. The process is sheer lunacy for those with intractable seizures. Surely you can find a better way. On to my talker, which is my official eye gaze computer. It is cumbersome and tiresome to use because of the calibration issues. I'll refer you to a recent scientific article that states, classic calibration methods, taking time and imposing unnatural behavior on the eyes, must be replaced by intelligent methods that are able to calibrate the signal without conscious cooperation by the user. Our time to speak is limited today, so let me make the most out of it. I want you to look into my eyes and those of my sisters and brothers as we sit here today. They are often clear and bright. I see you, hear you. I want you to know that we are trapped. My mother, father, grandfather, teachers, and therapists will tell you I am capable of clear, deliberate, intuitive thinking, and occasionally biting humor. My first physical therapist has shared with me that my motor planning is intact and perfectly normal. You see it now, don't you? It is my transmission that is broken. At the clinical level, I often feel that I'm seen as just a seizure nuisance. Read your own research. Nothing in it says I was born broken. I am, as you call it, delayed. It seems to say that when I needed my CDKL5 the most, it failed me. The seeds of my future are here. They need to be watered. My neuronal system needs to be rescued and restored, and I will do the rest. In a sentence, I want to walk and talk without the fog of drugs. With greater strength in my vocal cords and limbs, I may learn to talk and walk and grow, just like any other child does. Children learn in play, putting one neuron, synapse, and foot in front of the other. And let me not forget to remind you that increased strength and muscle tone will go a long way towards easing the cardio, respiratory, and gastro problems plaguing my brothers and sisters. Not to worry about benchmarks, Nothing is more measurable than movement, a spoken word, fewer medical issues, and lower bills. And I want you to keep in mind that CDD children are not unusual when it comes to seizures and motor issues. And the gene CDKL5 seems to be crucial across multiple domains, which gives me hope that there is light at the end of my tunnel. However, I must be cautious in my expectations. I am as unique as you are. Your genetic profile, including your deletions, your insertions, your copy variants, make me and you one of a kind. Unfortunately, we're not like cars wherein the model number dictates the parts we need. So, to all of your stakeholders, you tell me, where do I place my expectations? Do I choose the road of endosymptomatic treatments, like my current drug regimen, or a restart of my dormant CDKL5 gene, or a repair of my active CDKL5 gene? Finally, please see us for our potentials, not our symptoms and limitations. Isn't that what we all want?
Another truly incredible set of panelists. Join me in thanking them all for sharing their stories. So now we move into our second opportunity to extend the conversation with all of you here in the room and with our polling questions for those of you who have been following along on the web. I'd like to start with 2 polling questions that we have to get an idea of the range of experiences we have in the room with different treatment approaches. So if we can pull up our first topic 2 polling question, please. So here we want to know what medications or treatments your child is currently using. And here please select all that apply. So your options are A, anti-epileptic drugs, B, steroid treatment, C, experimental medications such as drugs in clinical trials or expanded access, D, formulations of medical cannabis, which includes CBD, E, vagus nerve stimulator, F, sleep medication, G, neurosurgery, H, the ketogenic diet, I, supplements, or J, other medications or treatments. And note our next question will cover non-medication treatment options like therapies, occupational therapy, physical therapy, and medical devices. So please select all that your child is currently using. And again, as with our earlier set of polling questions, the percentages displayed are a percentage of responses, not the percentage of people who have selected an individual response. Yeah. So this is to treat your child's CDD, any aspects of the CDD, yes. And other can include other pharmaceutical products not listed, for example, symptomatic treatments. Great question. All right. Give you a few more moments to log the different types of medications and treatments that your child is currently using to treat or manage their CDD. While final responses are trickling in, it looks like the greatest experience currently used treatments are anti-epileptic drugs, followed by supplements. However, there is experience in the room with sleep medication, ketogenic diet, as well as with investigational therapies as part of either clinical trials or expanded access, different formulations of medical cannabis, which includes CBD, and VNS. We have some experience with steroid treatment. No one listed neurosurgery, and we have people who have listed other medications or treatments, which we'll certainly want to hear about as part of the audience discussion. Can we go to our second polling question? So broadening the range of things that we would consider a treatment or approach to managing your child's CDD, we want to know the full range of things that you are doing to try to manage the symptoms. So this includes A, physical therapy, B, occupational therapy, C, speech therapy, D, hippotherapy, E, hydrotherapy, F, orthotic support, G, modifications or other accommodations in the house, H, eye gaze speech production devices, I, mobility equipment, J, nutritional support, K, approved pharmacologic therapies, L, investigational products or experimental products like those used in clinical trials, and M, some other way that you try to treat or manage your child's CDD symptoms. That's not listed on this slide. Please select all that apply. Give you just a few more moments to log all of the different approaches to managing and treating your children's CDD symptoms. All right. So as it stands, it looks like there's a few treatment options that there's the most experience with of those represented today. We have approved pharmacological therapies, which does include the anti-epileptic drugs. We also have a lot of experience with physical therapy and occupational therapy, speech therapy, a great deal of use of mobility equipment, orthotic support, and other modifications around the house. And then experience with all of the other different approaches to treatment and management listed on this slide, including many others that aren't listed on the slide. So we'll keep these responses up there to keep you thinking about the full range of different approaches to treatment that we might want to talk about. And now I'll give you another opportunity to raise your hand to participate. I will remind you, please wait to have a microphone to speak and state your name before you provide your response. So every treatment approach has benefits, has risks or downsides, has good things, bad things associated with it. I want to start with a question focused first on what are the good things, what has been working well or at least working best. And so of the different treatment approaches that we've just asked you about, what would you say are, for your child, the thing that has helped them most deal with their symptoms, treat their symptoms, or even just manage their symptoms in daily life? And if you could explain how it is really that you've noticed that particular treatment approach improving their life or helping them manage their symptoms, we'd love to hear that. So who would like to share a treatment approach that has working well or at least best of what you have available? Yes.
I'm Carol Ann from England again. So Amber was diagnosed just before her 4th birthday, and at that point she had been on 21 therapies for seizures just before her 4th birthday. When she was diagnosed, we knew that obviously intractable epilepsy was the main symptom and that we were probably never going to get control. So when she was 4, she went on vigabatrin. She went on a dose of 1,500 milligrams a day. She's only recently gone up to 2,000 milligrams a day, so at 1 sachet. For her, that was her miracle. A year later, she then had the vagus nerve stimulator placed, and she's now on her 3rd. Probably, I would say, within 2 years of the VNS being placed, she no longer had tonic spasms. So her seizure type is a non-motor. So sort of 9 years, she's been tonic free. Other than we know that when the battery starts running out on her VNS, she starts to have sort of stiffenings that start creeping back. So for her, that's been her magic combination. Yeah, but 22 therapies at 4 is not good enough, really. Not good
And
enough at all.
How long did it take for her to be able to kind of get to that, I think what you called it, miracle place?
So when she started vigabatrin, she didn't. It was almost like the convulsive element had been removed, and she was left with this long, complex, partial type presentation. So she would be sort of really flat, clearly not with it. But it was about a month after we started vigabatrin that actually we put it all in one dose. So she had, probably for about 8 years, her vigabatrin dose was in the morning. And that was when the tonic spasms kind of stopped. But in terms of what we have now, it was probably 2 years with vigabatrin and the vagus nerve stimulator.
Yes.
And
Yeah.
now she's on Translana or Atloren, and the morning seizures that she used to have on wakening, which would be the absences, the quite long absences, and they would be up to 20 minutes long. She no longer has them. So she might have the odd absence throughout the day, but certainly significantly improved on this compassionate trial of the nonsense mutation drug and vigabatrin, and she's now on a small amount of Keppra as well. So for us, we found that low dose drugs, not drugging her up to the point where she can't learn and she's sleeping all the time. And the VNS has been her magic.
Great. Thank you so much for sharing that. What else has worked well or?
Hello, it's Robert and Kate Gerlich from Westfield, New Jersey. It's our daughter, Lauren. And, in some way or form or another, we've tried almost every single one of these therapies. Without the horse, we got to make sure we pick up a horse on the way home. But without a doubt, the G-tube is the one that we probably fought the longest. And in hindsight, was, I don't know why, looking back, we waited so long. Lauren's seizures are a little unique, and I don't know if this is other families in the room have seen this, but her seizures come in clusters. We will go 3-4 weeks without really seeing any seizures whatsoever, and then we call it her bad week, and usually it's connected to her female cycle, and she has 2, 3, 4, 5 days of just where she's not eating, she's not drinking, she's just having clusters of seizures. So the G-tube, allowed us to get food and fluids and medicine in her when she's having those bad periods, and that certainly has been probably the biggest improvement in our caretaking and in her life. It's something we look back on, and it's always hard to schedule a surgery, put that on the calendar for your daughter, but in hindsight, that's the absolute best thing we did for her is to, get a tube in her.
Yeah. And how long has she been on the G-tube?
2015.
2015.
Yeah.
Great. Thank you. A hand here, then we'll come to the front.
Hi. I wanted to talk about the hypnotherapy. Our daughter's 23 years old. She does not bear weight. She does not sit up alone. But when we put her on a horse, she would droop forward. When the horse, as soon as it started to walk, she sat straight up. It was wonderful. We did this for several years. However, Carly she had a growth spurt, scoliosis. She has a chronically dislocated left hip because she can't speak to me. And she's tight when I put her on the horse. So I don't know if it hurts. So I don't do it anymore. But I highly recommend that therapy. I'd also like to say that Epidiolex has been our drug. She was on maybe 12 or 14 different drugs over her lifetime, plus the ketogenic diet. We were in the trial at Langone University, and while she was in that trial, we had to stay on one other seizure drug. She was in that trial for 4.5 years. We were going there. We have since taken her off the other seizure drug She is only on Epidiolex. It has cut her seizures over 60% and continues to do so. So I'm very thankful for that.
And what has that 60% reduction meant for her?
Oh, gives her days. She actually has sometimes a week without a seizure. She smiles. She is clearly happier. Even though she can't speak to me, she is clearly happier.
Great, thank you so much.
Sure.
So I'm gonna- Dan, if we can, yep. All right, we'll take a quick comment here.
Hi,
Yes.
I'm Kristen, and
Hi, Kristen.
Avery's mom. And I just want to say Epidiolex. Avery was been on Epidiolex trial for almost over 5 years. So we too were able to come off the other drugs. But one of the drugs that Avery's been on for 9 years is clorazepate for sleep. And she sleeps beautifully. So I just wanted to, she sleeps about 11, 12 hours a night. So, and I get sleep every night as a result of it. So I just want to kind of put it out there for the docs in here. I know he's over there, Dr. Davinsky, but she's been on this. Obviously, the dose has gone up over the years, but she's been on it since she was 2, and she's 11.
And what has the, I guess, predictable
And she goes to
fulfilling
school every
sleep-
day, gets up and functions, and
So when you started that and she was able to get sleep, what improvement did you see in her daily life? Once she was
just
able to
sleep. I mean, I couldn't do the night parties. I need my sleep. So, yeah, we tried a series of other drugs and nothing worked. Melatonin didn't work. Ativan didn't work. I don't remember at the time because she was only 2, but clorazepate has been our miracle drug. So I just want to let everybody know in the room that has children that aren't sleeping.
Great.
So
Thank you so much.
thank you.
All right, so we have a pair of comments up here in the front, and then, yeah. All right, while Dan's running, let's take this comment right here.
Yeah, I'll be quick. Landon Church. Landon is my son, age 9. I'm
You're
Miriam,
next.
and Atlanta, Georgia. Real quick on the Epidiolex, we started about 4 months ago. It's reduced GI issues and had a significant improvement on cognitive behavioral. In other words, for me, when I come by Landon now, he actually reaches out for me and puts his arm towards me, which is an enormous, obviously improvement for him from a cognitive perspective, and he knows that I'm there. The other novel therapy I kind of want to put forth as far as physical therapy goes is the intensive physical therapy. And to give you a perspective about how important this is to us, Landon was first able to qualify at 36 inches of height when he was about 3 years old. So we started him, they call it the TheraSuit therapy. We did a modified program. It's 2 hours, 3 times a week for about 8 weeks at a shot. We were driving about an hour there and an hour back in full traffic. And it was so important to us. We did it for 6 years in a row until they kicked us out of the program because he has a chronic condition. They couldn't hold a space for him because kids with surgeries required priority. So what we took away from that, though, was a home care program. And in that home care program, they have what's called a STEM therapy program, where you put, if you've had physical therapy, like on a sprained ankle or something, they use ice and they use stimulation, neuroelectrode stimulation. And so we bought a machine, hook him up to it twice a day. And it's really helped him to increase his head control. And with increased head control comes increased respiratory, secretion management, upper GI, lower GI motility improvements. So it's something that we've really, enjoyed. It's an activity that we do it together in the family. So I just wanted to add the STEM therapy.
Sure, thank you so much. All right, so we'll come here and then right here in the front.
I wrote down some things that I need to say. My name is Liam Fredericks. I am 9 years old. My brother is and Miles is my younger brother. Miles has changed our life by helping meet amazing people that can help us improve Miles's future, by making it so that he can work towards doing things other typical developing kids can do. These people are therapists, teachers, doctors, and other families and friends. Sometimes my little brother Miles stops breathing. I'm worried that he will choke. I get anxious that he could have a very big seizure and he could end up in the hospital for a very long time. I'm anxious and I'm curious about when my brother goes to the hospital with my mom about what's going to happen and when my brother goes to the hospital for a checkup because I don't know what's going to happen. I want to know everything.
Oh, Liam, thank you so much. You're a good big brother to be, so have so many insights into his experience, and so thank you for sharing that so much. And so before we give this comment, I just want to prime everyone else. Do want to broaden the conversation to also include the other side of the coin, which is any downsides to the treatments that you've experienced either currently or in the past. So in addition to what worked well, perhaps maybe what has not worked so well, or what have been the biggest downsides you've experienced. But please go ahead.
I think actually I'm going to piggyback very nicely. I was going to talk about something that's not listed, but peer and sibling interaction is probably one of my daughter's biggest motivators. She is most likely to take advantage of the things that she's learned in physical therapy, occupational therapy, speech therapy, vision therapy. When she is interacting with her sisters, with our neighbors, she just comes alive, and she is. It's just so important for them to have peer and sibling interaction. So while it's not a therapy, it's a really important part of our lives.
Absolutely. Thank you so much. Other thoughts, good or bad, about current treatments?
So I wanted to talk about a therapy that Lena really enjoys. I don't think we found a miracle therapy. Nothing has stopped her seizures for prolonged periods of time. Nothing has stuck, because we've been through periods where she lost everything and then we had to regain, and a lot of things we haven't and we're still working on. But for her water therapy, we can tell every single time we manage to get there, and we don't have a pool in our town, so we have to drive about 45 minutes to get to the pool, and 45 minutes back. And we were discharged because she wasn't showing progress, and the medical model requires progress in order to be kept in treatment. So now we were told to wait a few months and request a new referral. However, every time she was in water therapy, even the one time she was extremely fussy, you could tell she really enjoys it. It usually helped calm her down, and she learned to do things in water that then she was able to transfer on land that we'd never seen her do before. For instance, moving. So learning that moving her body is an enjoyable experience. She was a lot more still before we took her to the pool, and then we noticed that she was starting to move in her playpen on land, move her limbs, maybe even try to roll or reach, which she started to do first in water. And it was really, really exciting for us to see those developments. And I have actually been taking her to the pool after we were discharged just to try to get those same benefits. Something that was positive and negative, unfortunately, was the ketogenic diet. So we do not want to take her off of it. And we started it at 6 weeks. We were required to stop breastfeeding, which was absolutely heartbreaking for us at that time. She was 6 weeks old, and we were in the hospital. And we did notice an improvement in her cognitive abilities, in her attention, in her awareness. The seizures were never completely gone for long periods of time. I think the longest was 12 days that we had seizure freedom. But we are not taking her off, like it was said before, because we don't want to lose the potential cognitive benefits. However, when we increased the ratio, she stopped seizing completely, and we thought this was our miracle until she stopped eating, and she became overketotic, acidotic, hypoglycemic. We ended up in the hospital, had to take her off of that ratio down to the older ratio. She started seizing immediately, but she went back to eating. Right. Another drug like that was Sabril. She stopped seizing on Sabril. 4 days later, she was still refusing water, any liquids, any food. We took her off. The next day, she started eating. So anything that could have possibly been a miracle for us actually proved to be very detrimental. So we are very much looking forward to something that will give us, like I said before, not just seizure control, but a better quality of life for her, something like the water therapy.
Yes.
Something that she enjoys and can give her benefits.
Absolutely. Thank you. Just pass it right up.
Hi. So our Lulu has therapies basically every day for a few hours, and I feel it's such a blessing that we're able to give her the therapies that she needs. But the problem is, it takes a turn on her social life. So, she misses out on spending time with her siblings or, going with us to places. So it's a balance, you get all these therapies and you feel like your child's getting ready for the Olympics or something. But actually, it's what we need to do until we have some kind of treatment or hopefully one day a cure, and to just give them better quality of life. Because, for example, if we don't do the physical therapy, I can just leave my child rolling on the floor all day. So it's just a way of getting her to move, and then you can see the children enjoying being moved, whether they're taking steps or helping them sit up. So it's a balance, but we keep going as long as she's enjoying it and she shows progress. Thank you.
No, thank you very much. We'll come here and then over to Karen. Right here.
I made it complicated. The Olympics. Hi, so I just wanted to speak to two of, I guess, the downfalls to therapies.
Sure.
First and foremost, the amount of time it takes to get equipment. We have started, we've learned to start a year ahead of the time when Haley needs a new chair or needs new orthotics, because it takes that long for her to actually get the new product. As well as that, putting a ramp on our house, it took 6 months of planning and then another year and a half for it actually to get on the house. The other piece is the anti-epileptic meds, where frequently, as my dad had said, 16 different meds. The side effects of the meds we have found to be have more effect on her than the actual anti-epileptic effect. And what I mean by that is the drowsiness, that you lose that clarity with the medications. Even if you gain seizure control for a week or 2 weeks, or if you're really lucky, a whole month, you lose that clarity and the interaction that with the kids. And I think that's probably the hardest part of, you have to weigh, do you want your child to have that quality of life and to be interacting and eating and, functioning with you and have some quality of life, or do you want them to not be seizing? That's part of why I said that, the seizures don't bother her anywhere near as much as not being able to interact with the family.
Sure. Thank you very much. We'll take one more comment and then we're going to go to another polling question.
I was just going to comment one negative thing, like you were mentioning. So one of the medications we failed on was valproic acid, and interestingly, it actually did reduce her seizures. It seemed a little, but I didn't tell any of her teachers or therapists. Anytime we started anything new, I didn't tell anyone so I could get unbiased feedback. And the teacher and the therapist were saying her eye contact is amazing. It's like her attention span is better. And that was great. But she had a very strange and evidently rare vestibular reaction, and she stopped walking. So which would you rather, walking or attention span? So that was the drug we weaned. But the one other therapy that I haven't heard mentioned that I want to bring up is music therapy. For us, that is the one therapy that Samantha consistently meets her goals in. They're constantly reevaluating and making new goals. It's the one consistent therapy, no matter, even if she's had seizures, when that music therapist comes in, she will participate. She will pay attention. She will love it.
Sure.
That's all.
Thank you. I saw some nodding heads with the music therapy. So we have a pair of polling questions that are going to help wrap up our conversation of current therapy and get us thinking about future treatments and what it is that you would prefer to see in a future treatment. So if we can go to our third polling question for this topic. So thinking about all of the different medications, all of the different treatment approaches that we've talked about and the polling questions you all have shared so much about, can you answer this in general? How much have all of those helped improve your child's quality of life? Has there been A, no change, B, slightly improved, C, moderately improved, D, substantially improved, or E, are you not sure whether the treatments have helped improve your child's quality of life? So I'll let you think about that for a minute and get your response, kind of taking into account all that we've talked about, the benefits, the risks and downsides, the improvement that you've seen, if any, how much have the medications or other treatments helped improve your child's quality of life? All right, while final responses are trickling in, it looks like the vast majority of our participants today would say that currently available treatments have slightly improved their child's quality of life. There's, about just over 10% that have said that there's been moderate improvement or even substantial improvement. Another 5% each have said that there's been either no change or they're not sure. So we've only seen, in the majority of patients, slight improvement, which takes us to our next question. Thinking about future treatment, the question here is, which ability or symptom would you rank as most important for a possible new drug treatment today? And here you can select up to 3 responses. So given what you currently have, if you could think about what you could get from a future possible treatment, what would be your top 3 priorities? A, reduced seizures, B, improved developmental milestones, C, improved hand function and control, D, improved walking, motor abilities, E, improved vision, F, improved language abilities, G, improved social communication, H, reduced GI symptoms, I, improved sleep, J, reduced discomfort, K, reduced anxiety, or L, some other ability or symptom that you would rank as being most important for a possible drug treatment today. Again, select your top 3 priorities. Just as our general reminder, you're seeing the percentages of responses, not the percentages of individuals that have selected a particular response. I'll give you just a few more moments. Looks like most results are in. Of the options provided, it looks like the top ranked option as most important for a possible drug treatment would be improved developmental milestones. After that would be improved language abilities. And then the remainder of the options are fairly close together, with improved social communication, followed by improved walking motor abilities, reduced seizures, hand function and control, reduced GI symptoms. There are responses for each of the other abilities and symptoms ranked, so they're at least in some number of your top 3, and no one selected something else that wasn't listed on this slide. So with the remainder of our time, I want to continue this idea and this concept in a discussion of what it is that you are looking for very specifically from future therapy. So the way that I'll phrase this is short of a cure, because I think that's what we all would want. That would be the top of our list. But short of that cure, what is it that you would look for specifically from a next future treatment? And so, keeping these as things in mind, what specifically would you look for or want in terms of these options or other options from a future treatment? And why? Yes. Sure.
So I think, and just to echo what a lot of other parents have already said, is improved communication, being able to understand your child's wants, needs, pain, source of discomfort, and so on. How that comes is maybe of secondary importance. If it's spoken language, of course, great, but it may be non-verbal communication. And that, of course, does overlap potentially with hand use or vision, because one of those is likely to be necessary for a non-verbal communication. But I think that would really be life-transforming.
Sure. Thank you, Majid. Take here, and then we'll come
And
back to the
to
Senate.
piggyback on what Majid said, because he definitely took the idea right out of my head, but even to extend it a little bit, improved cognition, I think, would be really great to see. So to see Lina make association, to see her understand concepts or be able to signal that she understands who we are, respond to her name or respond to things that are said to her. So more complicated cognitive abilities, I think would be really great, would truly improve her quality of life, because it would allow her to interact with a world that, like Amanda said, may not always be tolerant of kids who are different and who express themselves differently. So her being able to participate more fully in a more typical way would give her more chances to, I think, enjoy her life more.
Great, thank you. So we have a hand right here in the middle. Oh, you got the mic.
To Vivi, who's 6 years old, and I would like to see improved muscle tone.
Okay.
I see that Vivi has intention to answer me, to move her hand on the choice board or her eyes on the eye gaze, but sometimes she has a very hard time because of her hypotonia. So, yeah.
No, that's very helpful. So we had a hand here, and then we'll come right up front.
I just wanted to add to what you had said. You know, what we use when we talk about Miles and improved is meaning. We would like things to be meaningful to Miles, whether that is in choice making, communication, understanding what he wants to play with, just something that can develop some meaning for him and his understanding of the world around him. And so I think that that involves cognition, vision, hearing, the low tone, and the developmental.
Sure. No, thank you. These different, slightly different takes on similar interests are very important, and so thank you for sharing that.
Yeah, I just wanted to agree with her back there about the muscle tone. You know, like Miriam said, improved muscle tone means improved secretion management and improved physical health. And I think, you know, if you're not physically healthy, you know, that's kind of the primary, wherein other things can sometimes be the secondary, especially if they create life-threatening situations. And my husband and I always comment that when Gregory has a tonic seizure, he has so much tone in his body, and I just wish that we could get that tone for other times, because it would greatly improve the quality of his life.
Absolutely. Thank you. So what else? Oh, we have a hand back here.
Hi, I'm Mark, Avery's father, and I agree with everyone in the room. I think important drugs to look into more is for communication and vision and motor abilities, and not to chase the seizures. I learned that a long time ago with Dr. Davinsky. Also, the seizures will come and go. Most of our children have seizures. They continue to change over the years. Avery's 11 now, and we've seen every kind of seizure under the sun. But we don't chase the seizures. We don't push the medication to the limits. We try to keep her on low doses of medication, and Epidiolex has been wonderful. But the seizures, we've learned, will come and go, and let's work on some of the other stuff and see what happens.
And what would you describe as what would be a meaningful improvement for Avery?
Communication would be huge for her to tell us how she's feeling, what she needs. She had a ruptured eardrum a week ago, and we found out about it, and we felt terrible. It probably happened days prior, and we didn't know about it, and that was devastating for us, a small thing like that, that she couldn't even tell us that her ear was hurting her. But that was very difficult.
Absolutely. Thank you.
Thank you.
We'll take a comment here, and then was there a hand in the middle or no? Okay, right here.
Cynthia again. Reiterating on what everybody is saying on the communication, I think not only for our ability to help our child, but you've got the soulful approach and the motor approach. And our children are incredible human beings, and I think that gets overlooked. We have our children who are looked upon as objects and problems to solve, when really they're human beings and lovely souls and beautiful people, and they're trapped. And from a communication point of view, not only for them to be able to communicate to us how they're feeling in painful moments when we can't help them and we have to try and figure it out, I want them to be recognized as people and human beings. And when we are out in the world, in society, when we take them to malls and we get complaints, honestly, I take those as opportunities to teach the public, and I purposefully take my daughter to places and make people get uncomfortable so we can be conversations and raise awareness. But I really communicate and bring out the human in them.
Sure. Thank you, Cynthia. We have time for one more comment. We'll end with Ed.
I'd just like to reaffirm what she just said about putting your children out there. They are human beings, and they all really yearn for inclusion. Movement obviously will give them some inclusion. For Haley, simply to be able to have a little more hand control and arm control and shoulder control would mean she'd be able to move the wheelchair down the hallway to the school and not be left behind, or follow you to the kitchen. It's not much of a deal. Maybe she won't be walking, but she'll be moving. The other part about it is I've noticed a lot of people were talking about yearning for communication. And I remember early on when we noticed Haley wasn't being responsive. And as I recall, it was probably 15, 16, 17 months, wasn't responding normally. And I don't know how we expressed our concern for one another, but I know I was concerned. And I made up a therapy on my own. I took out pictures. And I put them in front of me, and I separated them by, 6, 8 inches. I said, which one is mom? If the head went to mom to the left, hey, I know she's hearing me. And I know she knows which picture. And the accuracy was, superb, while she was having a seizure or tired. Now, she had no visual impairment, obviously seeing, but you got hard and soft and feeling if you're dealing with vision impaired. And the other thing I noticed after inquiring to other parents that are, overwhelmed by physical things is just a child's lack of communication may be represented intentionality. They're busting your stones. No, I'm serious. A common piece of language with Haley is you're changing her diaper, she's getting big, it's hard to get the diaper underneath her butt. So you say, butt up. She doesn't move, butt up. Hey, I'm only putting the diaper on, you're not going to the mall. Okay, butt comes up. I mean, it's, but, I'm making fun, it is funny, but there's a lot of receptive communication there that you really have to go for. Unfortunately, we live in a world where the therapies around they're not used to working with our children. So even if you get a well-intentioned, educated therapist in the house, they may not even be as capable as you are of making up stupid little things like that, like butt up and mom left, dad right. And what's important about that is, again, we have to look at them as not being the problem, but the opportunity, and they are there. And there is some way, and I thought today about the old book. If you really want to know what a struggle is, read the book about Helen Keller and Anne Sullivan, and you'll know people who persevered, through this. So, at any rate, thank you. They are all there, and we got to go look for it.
Thank you, Ed. So, this brings us to a close of the portion of the agenda where we've gotten to learn and hear and really appreciate from you all so much about what it is to live life with CDD, particularly throughout the topic 1 discussion. I couldn't keep track of the number of times that you all, parents of individuals with CDD, talked about how heartbreaking it was or is for you all to see your children and the different burdens and health effects that they're suffering from. And I think you all should feel so proud that today that you were able to share that heartbreak. I felt it. I'm sure everyone else here in the room felt it. But it was pulling back that curtain and sharing those difficulties, that heartbreak, that are going to be what allow us to move forward. We're going to now know what to target with therapies. We're going to know what is meaningful to you all when we see it from therapies. So I just want to thank you for spending this time with me as your moderator and sharing all that you did this afternoon. So give yourselves a round of applause.